this opportunity to present about management of diabetes, dyslipidemia, and overview of guidelines. As you know, this is a very, very important topic, and fortunately, this does not need any dose or time modification during Ramadan. Statin therapy and other anti-dyslipidemic agents can be used safely. So chimpanzees, they eat very little fat, and they have LDL levels in the range of 40 to 70, and they don't get atherosclerosis. So diabetes is now considered as a cardiovascular and renal disease. Actually, mostly it is compared with coronary artery disease equivalents, or we say that diabetes is a cardiovascular disease because it is responsible for 60 to 75% of deaths. And it is 2 to 4 times more common in people with diabetes, and the prevalence increases with age and the duration of diabetes. Now here we have a lot of younger patients, age 25 to 40, and they are at much higher risk of development of cardiovascular disease because they are going to be exposed to this risky environment. There are a lot of risk factors which are going to which are going to predispose them for development of cardiovascular disease over long time. Now, if you see the cardiovascular disease in people with diabetes, it is often severe, silent, and carries poor prognosis, and many of them may not reach to hospital also. There is a 50% before admission mortality. Another important thing to remember that it erases the protection conferred to premenopausal women. Premenopausal women with diabetes has higher risk if she has, because of the other risk factors also and presence of diabetes itself, in comparison to premenopausal women who does not have diabetes. So cardiovascular disease is the #1 cause of death in people with type 2 diabetes. You can see here nearly 52% deaths are because of that. Another important thing to remember that cardiovascular disease occurs much earlier, and it is the leading cause of mortality in people with type 2 diabetes. So in comparison to their non-diabetic peers, it occurs 10 to 15 years earlier. And we have a renowned cardiologist, and she knows that so many young people are developing cardiovascular problem and getting admitted with acute coronary syndrome. Another important thing is that presence of cardiovascular disease actually shortens the life expectancy of diabetic patient by 12 years. And if it is combined with renal disease, then the life expectancy is reduced by nearly 16 years. Now we have two kinds of risk factors for development of coronary artery disease. One is non-modifiable and one is modifiable. In modifiable risk factors, diet, blood pressure, diabetes, hyperlipidemia, obesity, physical inactivity, and smoking are. And hyperlipidemia is one of the very, very important risk factor which can be modified and treated easily. If you see the relationship between diabetes and dyslipidemia, nearly 97% of people with diabetes have some kind of dyslipidemia. And if you analyze your own patients, you'll find some have high triglycerides, some have low HDL. Most of them have this combination, and LDL levels are not, in some patients, they're not very much increased. They are slightly increased, but this can be misleading. It's needless to say that LDL cholesterol is the main risk factor for development of coronary heart disease, and this includes all these particles which are large or small, or LPA, and even IDL. And in people with diabetes, lipid-lowering therapy accounted for more than 70% of cardiovascular risk reduction. So if you see here, if you compare the control of lipids, HbA1c, and blood pressure, the lipid therapy, the lipid-lowering therapy accounts for 70% of cardiovascular risk reduction. So why the lipid profile in diabetic patient can be misleading? Because what you see in form of LDL levels, it may not be a true reflector of LDL particles. So people with diabetes, they have small dense LDL particles. So at the same number which you see, suppose 100, 110 of LDL in lipid profile, the number of LDL particles can be much more in people with diabetes. And these small dense LDL particles are actually more atherogenic, and they have more concentration of ApoB, which contributes to atherosclerosis. So dyslipidemia in diabetes is characterized by high triglyceride, low HDL, high LDL and small dense LDL, and high apolipoprotein B. And reduction in LDL level can lead to proportionate reduction in development of coronary heart disease. So you can remember roughly that if you reduce 1 millimole or 1 millimole or 30 milligram per deciliter reduction in LDL, you can reduce 30% risk of CHD. And this relationship is more stronger at the higher levels of LDL than the lower levels of. So there's a log linear relationship, and that is why there's so much of emphasis on LDL reduction in people with diabetes to reduce the cardiovascular disease. So the first guidelines which I'm going to discuss with you is the 2019 European Society of Cardiology guidelines. And one thing to remember, that when you are planning to start statin therapy or any lipid lowering therapy, it is better to assess the overall cardiovascular risk. And we have different tools, like American tools or WHO risk or European tools, which you can use. But most of the diabetic patient, they don't need risk calculator, because most of them, they qualify for high to very high risk category. And the other patient, you can see here, these are the patients where you even don't do the risk calculation. They are considered as very high risk patient, and they need moderate to high intensity statin therapy. So patients with documented cardiovascular disease, older individuals with long-standing diabetes or diabetes with multiple risk factors, familial hypercholesterolemia, chronic kidney disease patients, if there is a presence of carotid or femoral plaques, coronary artery calcium score of more than 100, and extreme LP elevation if it's being measured. Now, what are those risk factors which are going to help you in risk stratification of these patients, which are commonly present and sometimes they are being overlooked? So, presence of hypertension, smoking, chronic kidney disease, LDL cholesterol of more than 100, presence of left ventricular hypertrophy, target organ damage in form of presence of albuminuria or neuropathy or retinopathy which is documented, family history of premature CAD, and obesity or central obesity. So depending on the risk factors, if you see, you are going to do the risk stratification of these diabetic patients, and that is going to help you in deciding the LDL target. And you must tell your patient that what is that patient's LDL target and what are you going to do for that, and you would like them to be on their targets. So we have 4 risk categories as per European Society of Cardiology guidelines. So we have first very high risk, and in diabetic patient, if you see the very high risk category, this includes diabetic patient with target organ damage. Means suppose a diabetic patient having microalbuminuria present, or at least if they don't have target organ damage, 3 major risk factors. Suppose the diabetic patient is obese, he is hypertensive, or LDL is more than 100, he is very high risk category. Or there is early onset of type 1 diabetes and duration is more than 20 years. I'll be focusing on mainly diabetic patients. The high risk category. The high risk category in diabetics, it includes patients with diabetes without target organ damage and a diabetes duration of more than 10 years, or another additional risk factor. Suppose a diabetic patient comes to you with hypertension. That is considered as a high risk patient. Diabetic patient who is a smoker, he's a high risk patient. So even one additional risk factor, or suppose diabetic patient, type 2 diabetes particularly, if having the history of diabetes for more than 10 years. So that qualify the patient for high risk category. More than 90% of the diabetic patients, they come in very high risk or high risk category. Only less than 5%, if you see your own practice, that they will come in moderate risk, where the diabetic patient does not have any other risk factor. So it's a very less common to find diabetic patient in moderate risk. Majority of them, they go for high and very low, and there's no low risk category for diabetic patients. So how is this risk stratification going to help us in deciding LDL targets? Because patients, eventually they will ask you, what is my target? And when you are treating me, why are you treating me? Because when they see the lipid profile, they don't know what is their risk categorization. They don't know what is, they think that whatever is mentioned is normal and they don't need medication, and you are treating them unnecessarily. So this, you have to tell them that you have these many number of risk factors, you are in this category, and this is your LDL target. Now in European guidelines, one thing to remember, that their secondary prevention and the very high risk category have a same LDL target, unlike other guidelines. So here the LDL target has been decided as less than 55 milligram per deciliter or less than 1.4 millimole if patient is very high risk category and if patient is having established atherosclerotic cardiovascular disease. In high risk category, the more than 50% LDL reduction from baseline is recommended. The goal of LDL should be less than 70 milligram per deciliter or 1.8 millimole. In moderate risk category, the LDL goal is less than 100 or less than 2.6 millimole per liter. So how are you going to manage? So people with diabetes with very high risk, your LDL target is less than 55 milligram percent and you will need high intensity statin. With high risk category, you can see that their LDL target should be more than 50% reduction from baseline or should be less than 70 milligram percent. There again, you will need moderate to high intensity statin. So statins are recommended in these two categories because majority of the patients, they fall in these two categories. And intensification should be done before you consider combination therapy. Unless patient is not able to tolerate a higher dose, then you can use combination and you can, the preferred combination is ezetimibe because cost effective and it has proven cardiovascular benefits also. If that in some very high risk category patients, you can go for PCSK9 inhibitors, and in some patients where they are not able to tolerate intensity, there are non-statin therapies which you can use. Now, the last thing to remember in this slide, the type 1 and type 2 diabetic patient aged less than 30, as I told you that a lot of younger patients are developing diabetes now. If they have evidence of end organ damage, or LDL is more than 100, you can start statin therapy unless in a female if she's trying to become pregnant. The second guidelines I'm going to discuss with you is American Association of Clinical Endocrinologists, and it's 2022 and it was published in end of 2022. And here there are three categories. Unlike European guidelines, where there are four categories, the ACE guidelines have only three categories because they know that there's no low risk in diabetic people. Now here they have extreme risk, very high risk and high risk. The extreme risk category is for people with established established atherosclerotic cardiovascular disease or severe target organ damage. Or EGFR of less than 45, a patient is having left ventricular systolic or diastolic dysfunction. Now these patients, you will target LDL as less than 55. So here the extreme risk category is matching to very high risk category of European guidelines, where the LDL target is less than 55. Then second category is very high risk category, which is similar to high risk category of European guidelines, and LDL target is less than 70 milligram percent. So there's a slight difference, but it's up to you whatever guidelines you're comfortable with, stick to one, otherwise you will keep on getting confused. So here the LDL target is less than 70 and high intensity statin and addition of ezetimibe or bempedoic acid to reach lipid targets. The third category is high risk, which is similar to moderate risk in European guidelines. And here the diabetes duration is less than 10 years, type 1 less than 20 with less than 2 additional risk factors and no target organ damage. You can keep the target LDL as less than 100. In ACE guidelines, they have given non-HDL targets also and ApoB targets also. As you know, the non-HDL is a very useful target in people who have high triglyceride, and it can help you in detecting those patients where the LDL level shows falsely low or normal because of the high triglyceride. And their non-HDL cholesterol is very, very useful to decide. And the target of non-HDL is just, you can add the LDL target, 30 milligram percent in LDL target, and you will get the non-HDL target. Now the last and the latest one is the standard of care in diabetes from American Diabetes Association 2023 guidelines. So the goal of treating diabetes is, the main goal is preventing complications and giving good quality of life to people with diabetes. Now the diabetes is considered as a cardio-renal metabolic disease, and mostly the treatment is now cardio-renal metabolic and weight-centric. So glycemic management is one of the essential part of treatment. The second is weight management. Third is cardiovascular risk factor management. And the last is cardio-renal protection. And these are the four pillars of management of type 2 diabetes, with the foundation of lifestyle modification and diabetes education, which is a continuous process. Now you see these four pillars are glycemic management, blood pressure management, lipid management, and agents with cardiovascular and kidney benefits. So first and fourth, usually they join together. And when you target all these 4 pillars, you are going to reduce the complications of diabetes, and you will be able to give good quality of life to these patients. So we are going to discuss one of the important pillars, which is lipid management, which contributes to the maximum reduction in cardiovascular problems in diabetes. So, as you know, lifestyle modification is very, very important part. It does not only address the lipids, but blood pressure also, and overall health. Most of you must have read recently in the newspaper also the Mediterranean diet is very, very useful in people to prevent diabetes, hypertension, and having good effect on dyslipidemia also. So Mediterranean are dietary approaches to stop hypertension, which should include reduction of saturated fat and trans fat, increase of dietary N3 fatty acid, viscous fibers, plant-based sterols or stenols, increase physical activity. So lifestyle modification is very, very important, but most of the time people, they are not able to stick to it. Now, you should obtain the lipid profile as soon as patient is diagnosed, or a newly diagnosed patient, and if patient is qualifying for statin therapy or other lipid lowering therapy, you can start it and you can repeat the profile after 4 to 12 weeks. Usually after 8 to 12 weeks is much better, because then if patient is doing lifestyle modification also, that itself take 6 to 8 weeks to show the significant improvement. And once the patient is on lipids target, suppose that you repeated the lipid profile and patient is on target, then you can repeat it annually. If you are repeating more frequently, you are going to get the rejection and you will not be able to justify to insurance also. Now, if you have doubt about the compliance, or if you change some medication, if your primary target is LDL and other parameters are fine, you can just repeat LDL to make sure that the patient is taking and you can ensure the compliance. Because a lot of times people, they are playing with statin therapy without realizing that this is the most important one in reducing cardiovascular disease. So now we'll discuss in 2 parts: primary prevention and secondary prevention. The primary prevention, where the person does not have established atherosclerotic cardiovascular disease. So here the people with diabetes aged 40 to 75 without atherosclerotic cardiovascular disease use moderate intensity statin therapy in addition to lifestyle. In ADA guidelines, they have not mentioned the presence or absence of risk factor. They say that our age more than 40, all type 2 diabetic patients should be treated with moderate intensity statin therapy. Now, people who are younger, 20 to 39, with additional atherosclerotic cardiovascular risk factor. Suppose somebody is 30, 32, 35, and he comes to you with hypertension, or a patient is obese, a patient is a smoker, patient has family history, patient is microalbumin positive, then you can start statin therapy. But if suppose 20 to 39 does not have any other risk factor, which is very less likely, then you can skip the statin. Now, people with diabetes age 40 to 75 at higher cardiovascular risk, there you will start high intensity statin. In first category, they have not mentioned any risk factor. Means irrespective of risk factor, you have to start moderate intensity. But this moderate intensity will convert into high intensity if patient is having multiple risk factors, 1 or more other risk factor. And here your LDL target comes to less than 70 milligram per cent. Then people at age 40 to 75, and if your target LDL is less than 70, but if their LDL is more than 70, then you can add ezetimibe or PCSK9 inhibitor to maximally tolerated statin therapy. The statin therapy is contraindicated in pregnancy, or if suppose somebody is trying to become pregnant or planning to become pregnant in near future. What about the secondary prevention? Secondary prevention means patient with established atherosclerotic cardiovascular disease. Here you will start high intensity statin therapy from the beginning in addition to lifestyle therapy. Now, people with diabetes and atherosclerotic cardiovascular disease, treatment with high-intensity statin therapy is recommended to target an LDL reduction of more than 50% from baseline and LDL goal of less than 55. So, if you see here, all 3 guidelines have same view. Patient with established atherosclerotic cardiovascular disease, all the guidelines say that LDL target should be less than 55 or more than 50% reduction from the baseline, and they should be on high-intensity statin therapy. And if they are not able to reach to the target, add ezetimibe and PCSK9 inhibitors. Only in first 2 categories there is slight difference, but in this category there is no difference. All 3 have same opinion, all 3 guidelines. What about the other lipoprotein fractions or targets? So for individuals with fasting triglycerides of more than 500, you should evaluate for secondary cause of hypertriglyceridemia, and you should consider medical therapy to reduce the risk of pancreatitis. Now, in individuals with atherosclerotic cardiovascular disease or other cardiovascular risk factor, a statin, and who are already on a statin with controlled LDL levels, but still the triglycerides are high, like 135 to 499, you can add icosapent ethyl. These are the new fatty acids based therapies which have shown benefit in reducing the cardiovascular morbidity and mortality. The only thing is the cost is a factor because it's very costly. So now we are going to discuss about the two kinds of statin, you can say the classification of statin as high intensity and moderate intensity, because majority of diabetic patients are going to go either on high intensity or moderate intensity. And two most commonly used statins are atorvastatin and rosuvastatin. So in high intensity, only two statins are there, atorva and rosuvastatin. Atorvastatin 40 to 80 milligram and rosuvastatin 20 to 40 milligram. While in moderate intensity, same atorva, rosuva low dose and all other statins. But as you know that nowadays, mostly used are atorva and rosuvastatin. Now, if we see the statins and LDL reduction, the magnitude of LDL reduction, as you know, the most potent one is rosuvastatin with nearly 63% reduction in LDL from the baseline with 40 milligram of rosuvastatin and 57% reduction in LDL with atorvastatin 80 milligram. So the maximum dose, you can see the maximum reduction is with rosuvastatin followed by atorvastatin, and that's why these two are in moderate and high intensity, both categories. So no doubt rosuvastatin is the most potent statin, but one thing to remember that whatever statin you use, the first starting dose of statin brings down the LDL the most. That is the most effective dose. So if you see the 5 milligram of rosuvastatin, you will get nearly 45% reduction in LDL. And when you step up the dose, the reduction is additional 6%. It is not proportionate to the dose increment. So here you can appreciate it in a better way that rosuvastatin, atorva, simva and prava, the difference is from the first dose itself. The first dose of rosuvastatin, if you see the maximum reduction, then atorva, then simva and then prava. Now, fortunately, the similar trend has been observed in diabetic individuals also, that the rosuvastatin is the most potent one, reducing nearly 40%, you can say, reduction in LDL levels with 5 milligram, and then atorvastatin 10 milligram, 35% reduction, and simvastatin 10 milligram, 27% reduction. If you compare rosuvastatin and atorvastatin, rosuvastatin 10 is much more potent than atorvastatin 10 milligram. You can see that for additional, you can expect around 10 to 12% reduction in LDL, but this difference is slightly blurred when you go for the higher dose. In the initial dosage, the difference is much more. So if you see here in the first one, rosuvastatin 10 and atorvastatin 10, in different studies, you will find that nearly 10% additional reduction, 10 to 12% additional reduction in LDL with rosuvastatin if you compare rosuva and atorva dose to dose. What about the effect on HDL? This is very important because what has been observed that with the higher dose of atorvastatin, the HDL levels also they go down. But when you use rosuvastatin, actually this increases the HDL level. So rosuvastatin is the only statin which has the maximum effect on HDL increasing. The effect on triglyceride is nearly same. You can appreciate here that the different dosage is not much different in both between both the statins. Now, when you combine the high intensity statin and ezetimibe, you can expect nearly more than 65% reduction in LDL, and that is why majority of our patients will be able to reach to the target LDL goal with this combination. And then very rarely you will need the newer therapies. And newer therapies are also required in people who are not able to tolerate statin and people who are at very high risk and where the stringent LDL target of less than 55 is recommended by any means. What about the pharmacokinetic differences? So, 2-3 things to remember here, that rosuvastatin is not being metabolized by cytochrome 450 pathway, so it does not have much interactions. While atorvastatin and simvastatin, they have more drug-drug interaction. But if patient is having renal disease, then atorvastatin is the safest because atorvastatin has primarily hepatic excretion, and same as a fluvastatin. So in patient with kidney disease, moderate to severe, you should prefer atorvastatin. while rosuvastatin is having dual renal and hepatic excretion clearance. Now, important drug-drug interactions. If you don't remember this, no problem. Just remember one simple rule, that if patient is going on any antibiotic, tell them to hold statin. If you are not able to recollect this slide, no problem. Because with most of the antibiotics and antifungals, these statins can interact. But if you compare here, you can see that rosuvastatin has the minimal interaction with different type of antibiotics, macrolide and all, and even the antifungal agents. So you can see here that particularly you have to remember that, and atorvastatin, you can see that a lot of drug interaction you can observe. But with antifungals like itraconazole, ketoconazole, rosuvastatin does not have interaction. Even with macrolides also, it does not have. While with fluconazole and ketonazole, atorvastatin does not have reaction. With rosuvastatin, it has. So unless patient is having serious cardiac disease or underlying cardiac issue, then you can hold a statin for the period of antibiotic or antifungal if it is possible. Otherwise, try to choose the statin which is relatively safer. So with that, I would like to summarize that cardiovascular disease is a major killer in people with type 2 diabetes, and dyslipidemia is a major cardiovascular risk factor. And most of the diabetic patients, they don't understand the importance of treatment of dyslipidemia, and they tend to stop statin therapy repeatedly. And LDL reduction is the primary target, and optimal lipid control with moderate to high intensity statin, as most of the patients are at high or very high risk. Now, addition of ezetimibe or PCSK9 inhibitor is required if LDL goal is not achieved on maximally tolerated statin therapy. Rosuvastatin is a high intensity statin, which is the most potent one, leading to nearly 60% reduction with highest dose and 45% reduction with 5 milligram, with good safety and favorable benefit risk profile and few drug-drug interactions. So with that, I would like to end, and thank you very much once again for your patient listening, and we'll be glad to answer if you have any questions.